Why am I here today? Am I here because of the beautiful weather? It is a beautiful day, and in Canada it's the fall, so it's possible, but the answer is no. Am I here because I love coming to Portugal? Well, if you collect the evidence, I've been here 4 times in the last 2 years, so maybe the answer is yes, but the answer is no. I am here because I feel a moral responsibility as a clinician in the field of obesity medicine. You see, I feel a responsibility to share the principles of obesity because this is, in my opinion, the leading preventable cause of death and disability in your patients. I repeat, I'm here to discuss the leading preventable cause of death and disability in your patients. It used to be smoking in Canada. Now it's excess adiposity, leading preventable cause. So speaking of stigma, well, why don't they just eat less and move more? So diabetes does not have the entire license on bias and stigma. Obesity, we have a good portion of that as well. If they're losing weight, why have they stopped losing weight? Why are they not losing more? Why is someone overeating? Well, I'll be describing the answers to those questions today in terms of obesity as a brain disease. These are my disclosures. And the objectives are a secret agenda. What's my secret agenda? My secret agenda is to answer the question of if I have to cover only 3 things clinically with my patients. Can you give me 3 things only? And you're saying that I'll cover 90% of what behavioral therapy is in medicine if I cover these 3 things and I can focus on them? Yes. Describing obesity as a brain disease to your clinician colleagues and to your patients. 2, to understand the appetite response. I'm always describing this. When humans lose weight, their brain recognizes fat loss and fights against it with increased appetite. You need to tell your colleagues and you need to tell your patients. And then finally, what is the main symptom of obesity? If we treat asthma with medications, we are treating wheezing and coughing. If we treat osteoarthritis with medications, we're treating joint swelling and pain. If we're treating obesity with medication, what symptom are we treating? That's the third objective. And the answer is going to be an appetite-based phenomena. So let's jump in. I am the co-author, as mentioned, of the Canadian Clinical Practice Guidelines that are being globally adopted and adapted. We describe 3 pillars to obesity treatment. Behavioral therapy, again, the 3 principles I'm covering covers most of behavioral therapy. You'll be behaviorists after today, if you listen. Number 2, medication, great advancements in medication. And number 3, surgery. What you notice on that list is you see that there is not diet and exercise. What? Diet and exercise are not treatment for obesity? Absolutely not. We talk about diet and exercise in our guidelines as outcomes of treatment. In other words, if you treat obesity, people will be able to make changes. If you treat asthma, you don't tell people to breathe deeper and cough less. We treat them and they are able to breathe deeper and cough less. We don't tell people to eat less and move more. If we treat them, they are able to eat less and move more. You see, these are outcomes of treatment. As the great Lee Kaplan says, eating less does not treat obesity. Treating obesity results in eating less. So let's jump in. Obesity is a real disease I invite you to consider. Would you be surprised to learn that 70% of someone's risk of struggling with weight in their lifetime is conferred genetically? Would you be surprised to learn that the absolute great majority of those genes are in the central nervous system? We all inherit a unique appetite system with 3 layers, an executive system, which we have access to, you, me, your patients, and 2 lower levels, which are called the homeostatic, and the second called the motivational or hedonic system. By the way, to discuss the 2 levels as separate at the bottom is a misconception. The motivational and homeostatic drives work so interdynamically that really it's about one system that's at the bottom that we don't have access to, that's in our subcortical, subconscious areas of our brain, and this is where our weight is regulated, this is where our metabolism is regulated, this is where our appetite is regulated, this is where how our brain responds to fat loss is regulated, all in parts of the brain that we don't have access to. That doesn't sound fair. Yeah, that's where it is. And this appetite system evolved because we needed to be motivated to get food. How hard did you work for your breakfast today? Did you have to dig for it? Did you have to climb? Did you have to spend time crossing a river or climbing a mountain? The answer is no, yet your brain system is built to motivate you to do those things daily. That collides with our modern food environment, and you can imagine what happens. The brain, as I mentioned earlier, progressively defends against fat loss with increased appetite. For these reasons, we consider this a brain disease. Why the prevailing understanding of obesity? Why is there obesity crawling across our planet? The prevailing understanding is because it's a collision between this human appetite system and our modern food environment. The modern food environment, the calorie-filled, ultra-processed, ultra-available, ultra-sugar, fat, salt, ultra-portioned, ultra-delivered to your door in 5 minutes food environment. And that collision is the mechanism that drives obesity. And therefore, we consider describing that obesity is not someone's fault. Diabetes is not someone's fault, and obesity is not someone's fault. And we also then mention that treatment exists. In fact, as I mentioned, there are 3 pillars to treatment, and now you know where they work. Behavioral therapy addresses the executive system. I'm speaking to your executive system right now. The other 2 layers are inaccessible to us, and now you understand where medication and surgery work. They bottom up manage the physiology of obesity, and top down, we manage the psychology and behavioral principles of obesity as clinicians, and together, we get the best outcomes. Very quickly, genetically conferred, somewhere around 70% of someone's risk of struggling with weight in their lifetime is conferred genetically. Twin studies are a well-validated measure. Here's a systematic review. This is Ruth Luce. These are the greatest researchers in our field. This Claude Bouchard, a Canadian researcher, very world famous. Interesting point in this paper, he describes that yes, it's 60 to 80%, but actually the heritability varies across classes of BMI. So if you're sitting across from someone whose BMI is 35 or 37, you could bet that somewhere higher than 70%, maybe 75, maybe 80, maybe 85% of their risk of struggling with weight is genetic. We were talking about height earlier, how changes in insulin availability can create people who are genetically prone to be this tall, but because of the environment, and genetics in height is very significant, but because of environmental changes of people in India not having enough access to insulin, they don't get as tall. But otherwise, it's a genetic condition, height. And you don't see people beating themselves up about their height. Same genetics. Oh boy, if I worked harder, standing at the back of a concert, oh, if I worked harder, I could see the whole stage right now. I really should have just worked harder at my height all through my life. It's really my fault. Now we jump into the science of the brain. This is Ruth Luce and Gilles Yale, and the genome-wide association science has helped us look and find the loci, how many loci are there. They're describing in this paper around 1,200 different genes, all with variants. The real number might land at 9,000, stay tuned. And when you do a genome-wide association study, you can find the gene, and you can ask the question, what does the gene do? You can ask, where is it in the brain? And they're mostly in the brain. By the way, in diabetes, where are the genome-wide association studies? Where do they show the genes that impact diabetes? Below the neck. So it's interesting. So many here who study diabetes, this is the body, but here's the brain. Obesity is the brain. So it's a shift, I understand, for you. That makes sense. Okay, it's the brain. Get used to it. What can we do? So where the genes are, again, remember I mentioned, did you work for your meal today? And you didn't. But the genes are in the hedonic pathways, in both monogenic and polygenic obesity, the drive and motivation to food. Interesting. And this is the all-star of the researchers in obesity medicine, just very quickly to show you what they're saying. This is Kevin Hall, this is Sadaf Faruqi from the UK, from Cambridge. This is Ruth Luce, this is Stephen O'Reilly, this is Eric Rasmussen, this is Donna Ryan, this is John Speakman. Deidre Tobias, they describe the energy balance model. They say, listen, it's about the brain. It's a brain condition, and it's creating obesity because of this collision between our brain and the modern food environment. That's why it's here. So real disease, not their fault. Real disease, not their fault, treatment exists. That's the first thing. Now, I'm saying it, please communicate it to your patients. Number 2, expectations. How much weight am I going to lose, doctor? How much weight? I was told I should lose 30 kilograms. My surgeon told me I should lose 40 kilograms. When I was 18 years old, I was this weight. Should I get back to that weight? These are the questions your patients are going to have around weight management. We put it all under the umbrella of expectations. And in the expectations, the specific topic is very straightforward. It's about the brain's weight regulation system. Now, tell me if this sounds unfair. The human brain, all weight loss curves look like this, by the way. Actually, all treatment curves. If you give someone high blood pressure medication and you take their blood pressure every hour, it'll go down and down and down and down and slow and slow and slow, and it'll pull in somewhere. This is a treatment curve for all treatments. Tell me if this sounds like bad news. If you are successful in losing weight, your brain will recognize fat loss and fight against it primarily with increased appetite. To defend against fat loss, because if our ancestors lost weight, it was never good news. If our ancestors lost weight, it was not to look good for wedding pictures or because of bathing suit season. It was because not even that the food supply was interrupted, mostly microbial illness, according to John Speakman, also from the UK. Microbial illness and weight loss, and then we don't survive to pass on our genes, and then the species passes away. And so the system is to defend against fat loss with increased appetite. And that's why the shape of the curve is like this. Very quickly, here's Kevin Hall, who did a study using mathematical modeling. This is a 2024 paper. Kevin Hall at the NIH, originally from Canada. He did using studies that measure metabolic rate through indirect calorimetry or through doubly labeled water technology, studies that checked on body composition using MRI or DEXA. Using that data, he was able to figure out when people are losing weight, how many calories are they eating? And this is what happens. So here, just as an example, everyone should know that this is the weight loss curve that happens when you treat obesity. People lose, and it slows and slows and slows, and it pulls in somewhere. Please, I'm pretty sure you know that. But why does it have this shape? Let's look under the hood. This is what Kevin Hall did. He showed us that there are two curves in his diagram. One is energy expenditure. So as people lose weight, in this case on semaglutide, we see that in the first 3 months, because of skeletal muscle loss, which might be about 25% of their body weight loss, that because of that, there is a drop in energy expenditure of around 300 or so calories per day. The energy intake curve is the one that's interesting to me. You see people go on their diet, they start losing weight, they're eating 600 calories less right at the beginning, and then there's the dose escalation. That's what that little curve is, the little straight line. There's the dose escalation of semaglutide, and they keep eating less. The space between the two curves, by the way, is their weight loss, right? And then what you see at the end of the dose escalation is that their intake starts to go up and up and up and up and up. There it is. Aha! Do you see it? That is the brain's response to fat loss with increased appetite. And slowly their calories go up. Now, the patient will tell you, when it's slowing down, they'll say, I don't know what's going on, doc. I'm eating the same amount, I'm exercising the same amount, I don't know what's going on, doc. In your mind, you know that if they've lost 12, 13, 14, 15% of their body weight, they're facing an overarching drive and motivation to food that's actually resulting, it's in their subconscious, so they won't necessarily recognize it, but it's driving upwards in their intake. The final discussion today, the third thing you need to know about obesity, and this is why I came, is wanting. We talked about the collision, but what's the mechanism? The mechanism is something called incentive sensitization. This is the concept of wanting. Remember I said, what's the symptom of obesity that we're treating? What do the medications treat? What do the surgery treat? It treats the desire and the drive and the motivation to food, which it turns out is variable in heredity. It's mediated by a dopamine mesocortical, mesolimbic pathway from the midbrain up into the area called the nucleus accumbens, the motivational drive of the human to go and get. And in those who are vulnerable, and after enough conditioning, this results in excess wanting to eat, which results in excess calorie intake, which results in weight gain and results in obesity. And that's where we treat with surgery and medication. We treat this symptom. Our best mechanistic data that we have is functional MRI in humans. In mice, we've got great data. Here, all we really have, or the best mechanistic data, is the neural vulnerability that we see on functional MRI. The appetite centers light up when you eat tasty food through a straw, or you see pictures of desirable food. We even see that here in meta-analysis of 22 brain activation imaging studies. We can see the symptom of wanting in the human brain activated by tasting food or seeing pictures of food. And that's this wanting model. But what about hunger, Dr. Macklin? You're talking about wanting is the main symptom. What about hunger? Well, I'm first here to say that hunger has very little to do with obesity. If people ate just to the point where they were satisfied physiologically and they were meeting their biological needs for calories, there would not be a weight gain process in humans. And here we talk about, well, what about ghrelin? I understand when people go too long without food, they get hungry, they get ghrelin levels start to go up. Did you know that ghrelin is the strongest driver of wanting, craving, desire, urge? That's what you see here. This is the dopamine pathway that gets activated by ghrelin. And so to describe hunger and wanting as separate, it's really not suggested. I suggest that you think of the lower two parts of the brain as the motivation system. So I would not do a talk without leaving some clinical considerations. So I can't. I'm a clinician, and I write behavioral guidelines. And so based on these three principles, when a patient describes their story to me about obesity, I will listen, I will summarize what I heard, and then I will lean in and I will say the following. And I'm going to go through all three of what I presented to you today. This is the clinical part of motivational interviewing called the inform invite. I'm going to invite a patient after they've told me about their weight. I've listened. I've summarized what they told me. Did I get it right? This is your story? Yes. I'm wondering if you would consider the following, I will say. I'd love to get your thoughts on the following, I would say. What do you think about the following, I will say. I will say the science around weight has changed. We now understand this to be a real disease that is primarily genetic and brain-centered, strongly environmentally influenced, and progressive. Would you consider that you struggle with weight not because of a flaw in character or a lack of willpower? Here we're countering the stigma and the bias. Not because of being your fault, not because you're weak, not because you don't have enough willpower, not because you're not good enough, but simply because you're living with a real disease, untreated. And guess what? Treatment exists. Very effective treatment exists. Over the next 5 years, Portugal will experience the revolution of anti-obesity medications, second and eventually third generation anti-obesity medications that manage wanting, desire, drive, and motivation to food and defend against the brain's efforts to get you back up so well that you'll see effective treatment. Please tell your patients, real disease, not your fault, treatment exists. Are the treatments that are most effective available to everyone here in Portugal? Not yet. I get it. Also, access is a universal principle in Canada as well, but eventually, so you can start covering these three principles with your patients. Number two, an invitation. Dr. Macklin, I'm not losing weight anymore. I'm stuck. Dr. Macklin, how much weight should I lose? Dr. Macklin, I'm eating the same and it's not going anywhere. I'm only here and I need to be there. Invitation. I'm wondering if you would consider that all weight loss is always slows and slows and slows and plateaus. The brain defends against weight loss with increased appetite. I showed that to you. Would you consider that your mission is not weight loss? This is a somersault. Would you consider that your mission is not weight loss? Would you consider that your mission is to find, we've thrown out target weight, goal weight, ideal weight. They don't make sense. Would you consider that your mission is to find, discover, practice, what is the least amount of calories that you can take in, on average, while still very much enjoying your life and maintaining a loyalty to fun and food and friends and celebration and socialization at a level of effort you can keep long term? Would you consider working on that and then just standing back and let your brain and body tell you where it slows and slows and slows and pulls in? You're not stuck. This might be the best that you can do. We call it someone's best weight. Their best with just their efforts, their own, is here. Their best with medication is here. Their best with surgery is here. Depends on how much treatment they're getting. And then finally, would you consider that the main symptom of obesity is this motivation to food? This drive and motivation. It's a collision between our ancient brain and our modern food environment. And this is the main symptom. And this is where anti-obesity, If the brain did not defend against fat loss with increased appetite, anti-obesity medications would not exist. Anti-obesity medications exist only because the brain defends against fat loss with increased appetite. That's what they do. And so the world is divided into 4 people. The first group says, I get it, obesity is a real disease and I'm actively treating it in my clinic. The second group says, this seems really interesting and I see the comorbidity burden and I'm really interested to learn more. Tell me more about how does treatment work and what is most effective. The third group says, oh my God, my patients are coming in with asking for medication. I think this might be something that I have to do. I don't know how I'm going to integrate this into my practice. And the third group, and everyone fits into one of these categories. And the fourth group, rather, says, well, why don't they just eat less and move more? Or why don't they just do like me? I eat less, I exercise, and I don't struggle with my weight. So I tell them to do the keto diet, because I have lots of patients who do keto. And this whole nonsense about this being a real disease is just a way to give them an excuse, right? And so my goal of traveling the world is to get whatever level someone is in up to the next level. So go from 1 to 2, from 2 to 3, 3 to 4, and 4 to expert. That's my goal, and that's my hope for all of you today. Thank you very much for your attention.